Hello and welcome to the Pharma Learning channel. In this episode, we'll be covering pain management. Short-term pain like a sprained ankle is called acute pain. Long-term pain like arthritis is known as chronic pain, typically lasting longer than 12 weeks. The World Health Organization's 3-step pain ladder is widely used for the treatment of acute and chronic pain, originally developed for the treatment of cancer pain. For mild pain, at the bottom of the ladder, non-opioids like paracetamol or non-steroidal anti-inflammatory drugs, NSAIDs for short, should be used. Paracetamol should be considered alone or in combination with NSAIDs in the management of pain in patients with osteoarthritis in the knee and hip. NSAIDs should be considered in the treatment of patients with chronic, non-specific low back pain. It's called non-specific because it's not usually very clear what is actually causing the pain. There needs to be a cardiovascular and gastrointestinal risk evaluation when choosing an NSAID. Gastrointestinal problems like bleeds are more common in those over the age of 65, those with a history of peptic ulcers, and in smokers. Those considered high risk should be prescribed a proton pump inhibitor, PPIs for short, to use alongside NSAIDs for gastroprotection. Examples of PPIs include lansoprazole and omeprazole. NSAIDs like diclofenac and naproxen are linked to a higher risk of gastrointestinal side effects compared to low-dose ibuprofen. Coxibs like etericoxib, diclofenac, and high-dose ibuprofen have a greater risk of thrombotic events and are contraindicated in heart disease. Naproxen and low-dose ibuprofen are preferred in those at cardiovascular risk. Topical NSAIDs should be considered for chronic pain from musculoskeletal conditions, particularly for patients who cannot tolerate oral NSAIDs, like topical diclofenac for osteoarthritis. Other examples include topical ibuprofen and piroxicam. Topical diclofenac is available over the counter in a pharmacy as Voltarol. Topical ibuprofen is also available. Brands include iBelieve. Topical rubefacient are available over the counter as pain relief. Brands include Balmosa Cream, Deep Freeze, Deep Heat, and Algicel. For moderate pain, higher up the pain ladder, paracetamol and NSAIDs plus a weak opioid like codeine or dihydrocodeine can be used. Low-dose codeine and dihydrocodeine can be bought over the counter. Solpadeine Max contains 12.8 milligrams of codeine and Paramol contains 7.46 milligrams of dihydrocodeine. These drugs over the counter are restricted to acute moderate pain, not relieved by paracetamol, ibuprofen, or aspirin alone. Typically for 3 days only, no more than one pack of 32 can be sold in a single transaction. At the top of the pain ladder for severe pain, paracetamol and NSAIDs plus a strong opioid like morphine is used. Usually patients intolerant to morphine are given oxycodone. When a patient feels pain between regular doses of morphine, it's known as breakthrough pain. An additional dose known as a rescue dose may be needed. The standard dose for breakthrough pain is calculated as 1/10 to 1/6 of the regular total daily dose, which is given every 2 to 4 hours when required. If a patient needs frequent rescue doses, it can indicate inadequate pain control. Therefore, the strength of the regular doses may need to be increased. For subcutaneous use, such as in a syringe driver, diamorphine is preferred as the opioid of choice. It has a high solubility, which allows for a high dose to be given within a small volume. Opioids most commonly cause constipation, so laxatives like Senna or Docusec can be prescribed. Along any step in the ladder, additional drugs known as adjuvants may be used. Adjuvants include anti-epileptics like pregabalin, antidepressants like amitriptyline, and anxiolytics like diazepam. For neuropathic pain like diabetic neuropathy, amitriptyline, duloxetine, gabapentin, or pregabalin can be prescribed. Doses are usually titrated upwards according to response. Only one neuropathic pain drug should be prescribed at a time. Gabapentin and pregabalin have been reclassified as Schedule 3 controlled drugs due to the risk of abuse. For trigeminal neuralgia, which is a nerve pain in the face, carbamazepine, which is an anti-epileptic, is prescribed. Topical capsaicin is used for those that cannot tolerate oral treatment or when neuropathic pain is localized. When making drug choices, it's not always necessary to start at step 1, the bottom of the pain ladder. It may be most appropriate for severe pain to go straight to the top of the ladder for a strong opioid. When pain is controlled, the patient should be maintained on a dose that is most effective for them, or taken off pain relief completely if they are pain-free. Cannabis-based products can be purchased as a food supplement, available in health food chains and some pharmacies in various formulations, like an oil. CBD is only legal in the UK if it does not contain THC, the chemical in cannabis that makes a person high. There is some evidence that medical cannabis can help certain types of pain. However, the evidence is not robust enough to make a recommendation for its use as pain relief. However, cannabis-based medicine is available on prescription, usually initiated by a specialist. It's reserved for epilepsy, multiple sclerosis, and nausea and vomiting related to chemotherapy. Epidiolex oral solution is for rare forms of epilepsy. Nabilone capsules, known as the man-made version of cannabis, is reserved for nausea and vomiting in chemotherapy. Both Epidiolex and Nabilone are Schedule 2 controlled drugs. Sativex oral mucosal spray is prescribed for multiple sclerosis. It's a Schedule 4 controlled drug. Until next time, thank you for listening. Don't forget to subscribe to our YouTube channel. You can also find Pharma Learning on Instagram, Twitter, and Facebook.